I would say so, Caroline, because it does it automatically, so we're just transferred.
Okay. That's brilliant. Okay. Hi, everybody. It's great to see you all here today. My name is Caroline Cameron, and I'm the South East Region Unpaid Carers Manager, and I'm going to facilitate this session this morning. We've got some great speakers coming to talk to us today. We've only got half an hour, so the chances are we're not going to be able to have questions and answers while we go along. So if you can put any questions that you've got in the chat room, we can always put a question and answer information sheet together at the end of today. Can I also say please stay on mute, and we are recording this session, so if there's anybody here that doesn't want to be recorded, just please switch off your cameras. Thank you very much. So I would like to introduce, because we've got such a short time, I'd like to introduce our first presentation, and I would like to introduce, it's called Pride in Caring, and it's around LGB carers. And have we got Sam here? And can I hand over to Sam, please?
Hi, so I'm not Sam.
I'm
Sam is here, but I'm going to be presenting today.
Okay, that's lovely. Thank you very much.
Thank you. So could we just have the first slide, please? Great, thank you. So yeah, as I just said, my name is Keisha, and it's nice to be here. So thanks for inviting us along to speak today. I'm from Gadim. We are a health and social care charity based in Greater Manchester. And we received Mind the Gap funding, scoping and embedding, so phase 1 and 2, which was really great, to set up the LGBTQ+ carers network. Can I have the next slide, please? So our partners in this project are Manchester Health and Care Commissioning and the LGBTQ Foundation. So I'll take you through the background of the project, what we do, and our learnings from doing this project. Next slide, please. So as I said, we were really lucky to get phase 1 and 2 funding, and I think this quote from Carers Trust UK really captures the why behind the project. So LGBT people are more likely to be reluctant to access mainstream support, often due to a fear of facing discrimination and or previous negative experiences. So as I'm sure we all know, there's lots of carers support services available, and there is LGBTQ+ specific support available. But when it comes to kind of that dual challenge, there's a massive gap basically. So that's really where the project came from. Next slide, please. Thank you. So stage 1 was really about exploring that gap and capturing the experiences of LGBTQ+ carers. So there's not a lot of evidence at all, and by not a lot, I mean close to no evidence at all regarding the experiences of LGBTQ+ carers. That's true for the LGBTQ+ community in general. So we wanted to use this opportunity to take a look at experiences and what LGBTQ+ carers want and need. So this was kind of co-productive piece of work from the start. And stage 1 was really about establishing an LGBTQ+ carers advisory group, so that the group came together to share their experience and also their expertise in the development of a survey, which was distributed across the UK. Then from this, we produced the Can You See Us report, which has got a wealth of information. And from that, we could take recommendations of actually what was needed for this particular community. Next slide, please. So this is just a small snippet of what we got out of the survey. So you can see some figures on the screen, and I won't read through them all. But what came through quite clearly was a need for a space for LGBTQ plus carers, and a need for healthcare professionals and organisations to become more aware of the needs of this group and encourage inclusivity in carer support. Next slide, please. So stage 2 really moved into kind of implementing these recommendations. So the Carers Advisory Group from phase 1 became the LGBTQ plus carers network. So we're a group, we meet monthly online for an hour. We have socials, we have guest speakers in to speak on well, anything that the group decide they would like more information on. So we've had someone come in and talk to us about benefits and welfare rights. We've got someone coming in to talk about employment rights as well. Again, this was set up very kind of co-productively with our carers, so that was down to the structure of the group, the promotional materials, even the name. So you might have noticed phase 1 LGBT, phase 2 LGBTQ plus. So that was down to the group coming together and deciding that Q plus actually is more inclusive, and that's how we want to represent. I think for the group, a kind of big learning for us has been the power of the space itself. So we don't always speak about caring experiences. We don't always speak about LGBTQ plus experiences, but the space just gives everyone the chance to be themselves and be comfortable, not always relating to being an LGBTQ plus carer. We've also, another learning is around the carers themselves, and we have some carers who, you know, are kind of out and proud, who are really comfortable with their identity. But a learning for us have been around carers coming who are either kind of newly out or questioning or not yet out. So a good learning has been around having conversations with carers ahead of attending the group, or putting them in touch, a bit of a buddy up system with another kind of more experienced member of the group, and that's been you know, really powerful in helping people integrate into the group. Next slide, please. This is a quote from one of our LGBTQ plus carers who's been with us from the start, was involved in the advisory group right through to now, and I'll let you read it for yourselves. Next slide, please. So, as I said before, another recommendation that came from the report was this need for awareness and inclusion. So, again, co-designed with the group themselves, we developed this LGBTQ plus carers awareness training. As part of that, we recorded our carers' experiences. Initially, the idea was that carers would co-deliver the training, but as we all know, caring responsibilities, you don't know what's going to happen 1 minute to the next. So we decided a way to get around this was to record them experiences, because it's really important that the carer's voice comes through in this. So we deliver this, it's a 90-minute introductory type session. We do it via Zoom. It's free to carers organisations or third sector organisations. I'll give you I've got a feeling I've left the animations on the next slides. So next slide, please. Yes, I have. Maybe a few clicks, maybe 4. Yes, thank you. So this is taken directly out of our training, and these are our learning outcomes. Again, this was decided with our carers network about what they wanted and needed healthcare professionals to know. Next slide, please. Potentially a couple more clicks, sorry. Thank you. So this is an activity taken from our training, and don't worry, I'm not going to make you do it, and I definitely don't have time. I've just seen the 2-minute warning. But basically the idea here is a little bit like what Jen was talking about in the introductory section. It's getting that understanding of that dual challenge of being a carer and being LGBTQ+. And it might be more than a dual challenge, that there could be kind of other categorizations that are causing disadvantage and discrimination. Next slide, please. This is just a quote from a participant of the training. And I think for us, a learning from this training has been the need for further support for healthcare professionals and organisations. So this is introductory, and we do signpost to further training, especially with our partners at the LGBT Foundation. But we get a lot of feedback around, especially we do a section on LGBTQ+ identities and an understanding around that. And then we get requests for, can we support people to implement the things that we've put in the training afterwards? So a learning and a recommendation is there is more support needed to help organisations become aware and inclusive for LGBTQ+ carers. Next slide, please. Lastly, just our opportunities. We are still delivering the training. It is free, as I mentioned before, to certain organisations, but in terms of sustainability, outside of that, we're looking to charge organisations for this training, and then that will sustain the LGBTQ+ carers network itself. And please do share our details with your networks. Next slide, please.
Thank you. Oh, sorry.
Thank you.
Thanks, Keisha. That was brilliant. I'm sorry we haven't got any time at the moment, so all the questions in the chat, and we'll have a look at them at the end of the session if we've got any time. However, I would like to move on. Thank you very much for presenting. That's really interesting, great piece of work that you're doing. So if I move on to the second presentation, and we've got Amelia Abbott here, and Amelia's from Southern Health NHS Foundation Trust, and they've undertaken a project around tackling inequalities in service provision for vulnerable and lesser heard carers. So can I hand over to Amelia, please?
Hi, Caroline. Yes, I'm here.
Hi there.
Thank you very much. Can I have the first slide, please? So, as Caroline said, I am Amelia Abbott. I am from Southern Health NHS Foundation Trust, and we have been looking a lot over the last 2 to 3 years at how we work better with carers, families and friends in general. And that's both on the engagement and inclusion and involvement opportunities, but also on our front lines and how our staff collaborate with carers for the best outcomes of our service users. Next slide, please. So Southern Health covers a massive geography. It is quite wide, and we have so many communities within Hampshire. And for me, when I was presented with this opportunity to explore lesser heard communities of carers or those that are more vulnerable, I got a little bit carried away. And Caroline has been trying to rein me in a little bit in these lines of work, but I did get a little bit carried away. So we didn't want to just look at one population, because we have so many different communities of carers. So there's 5, and I'm going to try very hard to get through my slides and cover all of the 5 sub-projects that we've been working on. But this is just to give you an idea of those 5. Next slide, please. So I know this presentation is kind of meant to be about the findings and the recommendations, but I know that it was also about recognising some of the challenges that we might have faced in doing this project. The first challenge I would say is biting off a bit too much in one go for one 6-month project. But there are a few other challenges that we looked to overcome as well. Some of that was about building that trust, that rapport, that relationship with the communities. That can take quite a lot of time, especially if they have certain preconceived ideas about the trust or about the NHS in general. So that was sort of one thing that has developed, and you'll see as we go through the other slides where that was in particular. In working with other organisations, we did all of our work with collaborating with the organisations that were already serving those communities, because they already had that trust, that rapport, that we could then perhaps move into and sort of build up that relationship, not just with the carers, but also with the external organisations that we should be working closely with as well. But there was a little bit of gatekeeping here and there, in particular with certain groups, where obviously the organisations may also have preconceived ideas, or they may have been contacted by our trust in the past to do a piece of work, and then maybe something hasn't come of that. So there was a lot of sort of reassurance around that with those stakeholder organisations. Another thing that you'll see as we go through the slides is there were some communities that already felt so supported by the community around them, by those external organisations, that again, they were kind of like, well, what are you going to offer that's going to be additional and extra in supporting us as a community? And then finally, as we all know, it's been really difficult to meet face to face. And so we've had to just make it work as much as we could through things like Zoom or other ways of communicating. But it's so exciting now that we've got this opportunity to move forward in the environments that are more comfortable to the carers and those communities. Next slide, please. I'm not even going to talk about this one, but just to give you an idea of what our initial strategy was, our timeline, some of these have kind of got a little bit out of sync, but it's a work in progress. And for us, the whole point of this project was just to open that door and just to start that communication, start that engagement, and see how we could work together. Next slide, please. So I'll talk through the first subgroup. So this was older carers in rural populations in particular. I'm going to leave the themes and recommendations. You can kind of see those on the slide already. But the guys that led on this particular sub-project really found that in interacting and engaging with these communities, they started out by trying to deliver, questions by phone call over, interview questions by phone call. And it just really didn't work for this population. What they found worked really well was being able to get their team, the urgent community response team, nurses and healthcare professionals, clinicians on board and actually actively asking those questions themselves. So that sort of trust, that relationship was already founded between the clinician and whoever they were going to see. So they were able to gather more insight and information that way. They have a few recommendations and next steps. You can see them on the screen, but I think one of the really nice ones in this is embedding the question of how are you to the carers. And I just think that's a really just simple, small step in the right direction. Can I see the next slide, please? So the team also produced some packs, and I think that's maybe coming at the end. I don't know what order the slides are in anymore. Young carers. Young carers, I led on this piece of work. We did this alongside Hampshire Young Carers Alliance, which is a set of sort of 10 young carers groups all across Hampshire. And initially what we did was send out a survey to the young carers, asking them how much they knew about Southern Health, how much they knew about their loved ones' health conditions, but most importantly, how could we better engage and support them as young carers? And the findings so far, it's just preliminary data at this point, but the key themes that have come out are the 4 that you can see on the screen, which are obviously in line with the recommendations moving forward. But a lot of it is much more co-production, much more working collaboratively with different organisations. There's one in particular on there, developing opportunities to work collaboratively with schools. Just yesterday, we had our first youth roadshow, which was absolutely wonderful. And as part of that youth roadshow, which is all about raising awareness and education of mental health amongst young school-aged children, we had a section in there specifically to young carers. And I think that's important, isn't it? Is embedding that within every single conversation we have, is recognising carers are a thing as well. So next slide, please. The Travelling Gypsy Communities sub-project was a little bit slow. And the reason for this is because we found that actually those communities really struggled to engage specifically over the winter months, because there was obviously a lot more that they were having to deal with. But we're working very closely with the Margaret Clitheroe Trust, and we're putting in posts, paid roles and volunteers for that outreach, so that we can develop this project further. Like I say, some of these, there's more work to be done. Next slide, please. We also worked with local organisations such as the St Denis community around minority ethnic communities of carers. And again, they found some incredible themes. This was a piece of work that they were already starting to deliver on, and we've been able to utilise that. There's no point in reinventing the wheel or restarting a project. But we've explored those themes in a bit more detail over the last 6 months and come up with some recommendations moving forward. The first is our mental health awareness event, which is coming up very soon, and it's very exciting. We've harnessed it as a mental health awareness and wellbeing event, but in particular the group of carers and service users that were involved in that piece of work were really adamant that they wanted to hear from psychiatrists from minority ethnic backgrounds as well. So we've made sure that we've embedded that within it, but the awareness event is actually open to all, so anyone can attend that. And then we have some steps that we'll be working on over the next year with them as well. Next slide, please. And then the military families and carers community is quite a high population within Hampshire, for obvious reasons, Portsmouth, etc. What we found with the outreach that we did around this was that actually networks were already so solid for this particular community that there was this little interaction of, you know, what could we offer as additional? There was a bit of lack of clarity around what that offering might be. And so I think that's something that we're going to develop further, in particular with the networks that we've now developed, and sort of learn from the people that are already supporting those families and those communities. You know, how can we better link in? Is there anything that they do need in terms of healthcare provision? So we're continuing with that. Next slide, please. So our next steps are to continue with the lines of work that we've already been delivering on, because we're really proud that we've been able to, you know, engage 5 different communities of carers, but realistically we want to embed it everywhere, and there's so many other communities that we want to support and engage with as well. So moving forward in the next couple of years, I don't know how long it'll take, let's just try and conquer the world of carers all across Hampshire. That's the dream goal. Next slide, please. Final, next slide. One last slide. Here you
Right,
go.
one last slide. Okay.
That one image that I was saying about.
Okay, Amelia, is that you finished, Amelia? Are you happy?
That's me. Thank you.
Okay, that was absolutely fantastic, and really appreciate you coming along today to have a chat. You've got an awful lot of work going on in Southern Health around carers, so thank you very much for doing that piece of work for us. And now our final presentation is Amelia Clark, and Amelia's going to talk to us today about hidden carers and early identification project. And hopefully Elaine's here as well to support that presentation. Amelia,
Hiya, yeah.
take it away.
It's Amy, not Amelia.
Oh, sorry. Oh, gosh, sorry. I'm
worry
thinking of my
about
last
it.
presentation. Apologies.
And, don't worry about it. Unfortunately, Elaine couldn't make it today, so it's just me.
Oh,
but
right.
she's
Thank you.
shared the slide. Have you got some the slides?
Yeah. Can you see them?
I can just see the first that page there. It says hidden carers. Have you got the rest of the? There we go.
Yeah, of course. Yes.
And hi everyone, I'm Amy, not Elaine. And I'm the service manager for the Carers Hub in Rochdale, and I'll tell you a bit more about the Carers Hub. Next slide, please. So we provide a single point of access for all carers throughout Rochdale to access information, support and guidance on the caring role. And we're delivered by Encompass, which is a wider charity in the north, which operates advocacy, carers, health and wellbeing, counselling and volunteer services. Next slide, please. So just a bit of a background to why we chose the early identification project. During 2019 and 20, the Carers Hub in Rochdale carried out a pilot project working with GPs, and we found that there was a 70% reduction in the number of times carers visited the GPs in relation to their physical health needs when they were identified as a carer and when they were receiving support as a carer, and 72% reduction in the number of times they visited their GPs in relation to mental health needs. And then some data there regarding the pandemic, so caring behind closed doors. More than half of carers saw a physical impact on the health through the pandemic, and 64% said the mental health worsened. So we're really keen to explore a bit further how we could support carers with relation to their GP surgeries and how we could get them on board. Next slide, please. So an outline to the project, we were very aware that as a provider of carer service, we didn't have free access to carers directly the way that primary health does. So we wanted to work with up to 6 GP practices to train them in carer awareness, promoting identification and opening up those referral pathways. Training in one particular GP practice that I delivered with one of my colleagues resulted in 7 new identifications the following week, and then it increased over time as well. So the second part of our project, aside from working closely with the GPs, was to also hold consultation sessions with carers to hear about their journey, how they identified as a carer, develop some key indicator moments, and what we could explore that further with GP practices and other health organisations. And we heard from carers that they wanted to be seen, with an average of 17 years spent caring before they were formally identified. And some other things that we identified was that there wasn't really a fixed definition of when a wife, a mother, a father, a daughter crosses over to becoming a carer. Next slide, please. So our project delivery. So some of our successes were that we developed some key indicator moments of when they could have been identified as a carer and weren't, or when they were identified and it went really well. We found that some of the carers felt it was quite cathartic because they got to, for the first time, tell their journey, their story of becoming a carer. It gave GPs a real understanding of caring because we were able to give them some examples of what carers had told us about their journey, about their experience of being in GP practices and beyond. We were able to capture some really good best practice examples and share those with surgeries. And we were also able to enable some adaptive practices. There was some challenges, as you can imagine, with COVID. The timeframes of the project meant that we had to be quite patient with GP practices and with carers as well. The capacity of the GP surgeries, as I'm sure lots of you are aware, GP surgeries were not allowing people to come into the practice whatsoever. So in order to deliver that training, it was really, really challenging for us to pin down some of the surgeries and locations as well. So we had to adapt the way that we delivered the training, adapt the way that we delivered the consultation sessions. There were also very varying commitment levels. We'd have some GP practices saying to us that they were very on board with doing the training, and then at the last minute they would pull out because of their own commitment and their own capacity. Next slide, please. So some of the outcomes, as I mentioned before, the carer awareness training resulted in 20+ referrals just in one GP practice alone. We also increased contacts within GP surgeries, and therefore we also increased our offer because we were then able to deliver the training to GP practices. And we also came up with an identification checklist that we were able to pass on to GP surgeries, and we have created some really great posters that are going to be in the waiting rooms at GP practices throughout Rochdale and also in the staff rooms at the GP practices themselves. So one targeting carers directly and one targeting GPs. So we heard from the carers themselves, we captured their stories, and we've shared this widely as well with their consent, of course. And it was really interesting to see the difference between, for example, 2 carers that were part of one of the consultation sessions. One of the carers was caring for over 20 years before being identified and was completely at crisis point. She described herself as keeping her nose above water all the time, whereas another carer was identified very early in a caring journey. She got a support support systems in place at an earlier stage, and she wasn't at crisis and she was managing fine with really good support systems in place. And we also had really higher engagement levels as a result of this project with the carers. The carers who came to our consultation sessions, we were able to promote some of the activities and support that we had available to them, and now they're engaging a lot more than they previously had done without the consultation. Regarding longevity, so we have more marketing, promotion and awareness targeted directly at GP practices and how they can become more involved in carer services. We're planning to roll this out throughout all our carer services in Encompass, because we operate also in Lancashire, we operate in Staffordshire, Carlisle, Cheshire, so we're hoping to push this out further. And we are now working much more closely with carers leads throughout the Northwest, and supporting with contingency planning and with PCNs and LCO board as well. Next slide, please. This is just one of our posters. So this is the poster for that's aimed directly at carers. So if you can see on this poster on the left here, we've got lots of little dots. We had an artist come to one of our consultation events and asked her to capture things. And this picture here represents 22,000 hidden carers in Rochdale. So we came up with an acronym here on the side. We can see carer, and just when we said about them, indicator moments, pointing out to carers how they can identify themselves as carers, and then importantly at the bottom, an action pathway, what to do when you have identified yourself as a carer. Next slide, please. For GPs here, we've got another acronym, a little bit different from the carer acronym. It's talking about consideration, how you can identify a carer, not just necessarily asking the question, are you a carer, but looking, who are they coming into the surgery with, who are they collecting medication for, what are they saying about their own stress levels, and open up those conversations that they might not have been able to have had before. And again, really importantly, an action pathway at the bottom. What do you do once you've identified as a carer? And we try to make it as simple as possible for the GP practices. Next slide, please. That's it.
That's great. Thank you very much, Amy.
No problem.
Right, well, that was really well timed. You got through that great presentation. So interesting to hear how you're linking in with the GP practices, which is obviously a very challenging, and you managed to get some really good outcomes from that. I think we're now going to move into the main room. So we'll all see you in the main session in a couple of seconds, I think. We should move
Caroline?
now. Yeah.
Caroline, I think actually we're staying in our allocated breakout rooms.
Oh,
so
right,
we can just
okay.
go off for the break because we're going to keep the recording going.
Right.
Then we'll do the second half, and then Steve will bring us in back into the main room after that. So yeah.
Lovely. Okay then, so we've got a 10-minute break now. So if people would like to go and get themselves a cup of tea or coffee, and we'll see you back here in 10 minutes. Thank you very much.
Okay, I'll introduce myself. So my name's Jodie Dids. I'm the carers lead for the East of England region, and I work alongside Caroline and of course the national team. So we're due to restart this session 2 at 12:05, and I can see people kind of popping back in. So because of time, we will start. So we moved to Cambridge and Peterborough for our next project, and it's looking at support to Gypsy and Traveller carers. And if I can invite Jill to join the chat or join the presentation and share with us what she has been up to. Thank you.
Yeah, hi everyone. So yeah, it's not Andy today. You've got me. So my name's Jill and I'm from Caring Together. So can I have the first slide, please? So Caring Together, we are a charity that support carers in Cambridgeshire, Peterborough and Norfolk. So we had the part 1 and part 2 funding for Mind the Gap, and we focused on looking at Gypsy, Roma and the Traveller community. Okay, next slide, please. So my name's Jill Noy and I'm an awareness and voice coordinator. Next slide, please. Okay, so what did we learn? So I think one of the main learning that we took from this was actually that this community were really hard to reach directly, and the best way to do that moving forward was to work with the trusted professionals that already had those relationships with this community. It took us a while to discover that. We originally started to reach them directly, but found this was a much better way, especially with COVID still around and people not meeting as they would normally. So what we learnt from these professionals was that the literacy was a barrier. So we created an easy read publication that was something that a carer was able to pick up and see who were the right people to be supporting them. So it wasn't just looking at the information from Caring Together, it was looking at other local organisations and charities that were able to support a carer. So what I really wanted was that information sort of encompassed all the local support rather than just us, so we work collaboratively with our partners as well. We learned that WhatsApp was really well used within this community, and actually that they share lots of information through WhatsApp. So one of the key workers had shared that actually they would often receive a picture of a letter and then a voice note from a member of the community saying, can you tell me what this letter says? And they would share health information through their group chats in WhatsApp. So something that we are looking to further produce is sort of an audio version of the Easy Read document that could then be shared through platforms such as WhatsApp or even Facebook and things. So sort of using that link through YouTube. So that's something that we're going to work on. We also wanted to kind of use that approach of being able to provide support through those trusted professionals. So we really built those relationships with those trusted professionals, those link workers that are already working with the community. So we're in regular contact with them. I delivered the Easy Read publication to them and just kind of keeping, you know, my face and just keeping carers on the agenda when they're working with this community. And kind of just still learning from them, really. That's kind of ongoing. We also had to change our processes because we discovered quite early on when we were looking at emergency planning for carers that taking personal details was a real barrier and form filling was a real barrier. We provided bursaries to this community for lots of different reasons via the link workers. But as we would normally do through a bursary route, we would send out an application for a bursary, which would ask for sort of personal information, reasons for the bursary. For this community, we scrapped that and we just worked directly with the professional that was working with the community. So we didn't even ask for, you know, real information or names. It was just give us a general picture of what this carer needs and how this will kind of support them and what we can provide. So yeah, we had to kind of change the way that we work. Okay, next slide, please. Okay, so what we achieved, so again, going back to one of the biggest successes was that work through the link workers and those professionals. So that's something that we're kind of really proud of and kind of working with, you know, with other professionals like health visitors, etc. We also ran an awareness training session for health professionals. So that was through Friends, Family and Travellers, that was looking at sort of the cultural needs of the community. It was really good because we reached a variety of different professionals. For example, we had some health visitors that were going to visit families after they just had a baby. And actually they learned so much about the cultural needs and the cultural issues around childbirth, and it's simple things like not being able to make a cup of tea and serve dinner for a certain amount of time after you've had a child. That was something within the culture that they weren't aware of. So it kind of opened up those questions, actually, how can we better support this community with that knowledge? So the other thing was, again, looking at the format and actually how are we getting that information to this group. So like I've said, use the use of WhatsApp so that they can share that information. From the learning that we've achieved through this group, we've also secured some funding to do some more work with this community based in Norfolk. So we're really excited about that, and that has just started. So yeah, I think that's a really good achievement. That shows that actually what we've learned from here has been useful, and we can then use that to kind of progress and support more people. Okay, next slide, please. Okay, so the continued joint working with the Professionals Network is something that's continued through Health Watch. So they're one of our partners in the local area. They are working on a similar project to work with this community, and we've kind of worked collaboratively through this. They are taking over some of the work from us. So I set up a workshop for different professionals that they are then going to take forward. So we will still kind of feed into that, still be a part of that. We have put this learning into our business as usual in the support that we offer for carers. So like I said, the easy read document that will be accessible to anyone and everybody. And we will also continue with that audio content to be able to share that, which I think will just reach, many people. The connection with the link workers and the professionals is something that we are still working on. We're still sharing information. They're still keen to kind of look at carers within that community and actually support and identify more carers from that. And as I mentioned, we've secured this funding for the next project as well, which is really exciting. Okay, next slide, please. Okay, so any questions? If we have time.
Well, actually, we do have time. Jill, I think you're 4 minutes ahead, so that's excellent. And we only have 2 presentations this afternoon, so in this next half-hour section. I see a hand up from Tanya.
Hi, yeah, thanks, Jill. Really interesting stuff. I was just interested to know which Health Watch are taking that work on. Was it the Norfolk or is it?
So no, it's Cambridgeshire and Peterborough.
Brilliant.
Sorry, crying child. Yeah, Cambridgeshire and Peterborough Health Watch. So they have learned from some of the things that we found, and they've kind of found the same things as well. So it's been really great to kind of share that and work collaboratively. But yeah, Health Watch, Cambridgeshire and Peterborough.
Thank you.
Okay, and there's just a chat that Neil's put in, Jill, was how is the idea of being a carer perceived in the Gypsy, Roma and Traveller community?
Yeah, it's really difficult. The word carer just isn't recognised at all. And we've sort of been looking at actually what support do you offer, and actually being a family member, and actually could that family member support with work without your support, which is commonly not the case. So it's looking at we use the word carer, but maybe when we're communicating with that community, not using that word, and just say, if you help a member of your family, that kind of thing.
I think that's so important, and I think it's such a common theme throughout all the projects, and a lot of the work is that we really need to think about the language that we use, especially working with more vulnerable communities, and try and find a common word that suits their needs. And again, as an organisation, adjusting our requirements to meet the community that you're dealing with. So that's really good. I'll move on to the next presentation, and then I think if we will have that time at the end, and we can open it up to general questions as well, and possibly questions from the session 1. So this presentation is engagement, consultation and co-production with the refugees, asylum seekers and migrant communities in Stockton-on-Tees. So we're moving to the North East and North Cumbria area, and I think we've got John who will be presenting. So can I invite you, John, please?
Yeah, thanks very much. Hi, I'm John Carling. I'm Chief Executive Catalyst. We're the voluntary sector infrastructure organisation in Stockton. So can I have the next slide, please? Thank you. So, you know, we do lots of work with lots of different voluntary sector organisations all the time. We support what they do in terms of helping to find funding and governance and that kind of thing. And in the course of that, we have a member of staff who or post, which for the last 2 or 3 years now has worked closely with refugees and asylum seekers, providing them with support. If you're new in the country, you probably don't know how to get in touch with your GP. You'll know very little about schooling arrangements and that kind of thing. We'll help them to do that. And we work very closely with Stockton-on-Tees Borough Council as we do that, and very much a partnership in the delivery of this project. It was interesting to hear what Jill said, because there are, you know, a number of resonances between what was happening in her area and what's happening in Stockton in this project, particularly around cultural differences and the use of language, and I'll come on to those. So can I have the next slide, please? Right, so Stockton is a borough of about 200,000 people. It's in the deprivation statistics, it tends to sort of figure about halfway, you know, sort of somewhere in the middle. But actually, it's got the biggest gap, the biggest range between affluence and deprivation in the country. So there are some very significantly deprived areas in Stockton. We've got one of the largest populations of refugees and asylum seekers in the northeast. There are over 700. That's second only to Newcastle. And from a lot of different countries in the world, you know, from different parts of Africa, from South America, from the Middle East, from Eastern Europe, and so on, and certainly numbers coming through from Ukraine in recent weeks. Often those people are very highly skilled. You know, you're talking about people who have significant qualifications, you know, medical qualifications, legal qualifications, and so on. And I guess if you're going to make your way from a distant part of the world to Stockton, then, you know, you need a certain amount of nous to find your way of doing that, and that, I think that shows through. They also receive support locally from a range of different organisations. Obviously, the statutory organisations such as the council and the NHS and so on. They do a great job in terms of helping people to settle in and providing them with services. And from more informal bodies, there are any number of small organisations, some formally constituted, some just people that meet on a regular basis, whose role is to support refugees and asylum seekers. Very often, those bodies or those groups focus on a particular country that people have come from, or perhaps a particular religion or ethnic group, and I guess it's our job to support them. One of the things that we found in this is that, you know, word of mouth is the way to communicate. Many of these people speak English, many very, very good English, and, you know, there's often no substitute to talking. I've got to say that access to digital communications isn't always straightforward. So you know, having those kind of face-to-face conversations really works. So can you go to the next slide, please? So we started this project with some consultation. We got together 3 focus groups of people from refugees and asylum seeker communities. There are a number of drop-in centres that the people that we're talking to attend to help, you know, to meet other people and to access services. We went along to those and had conversations there. And we also just did a survey asking about, you know, experience of caring, who is a carer, and what does that mean. First thing that came out of this, and this is, I think, that pretty well the same as what Jill said, is that using the term carer tends not to work. You know, what does it mean? It's not something many people are not always familiar with that. If, as my colleague Lauren did, you walk in and say, "Hi, I'm Lauren, this is what I do," and you open up a chat, then you can get into a conversation which might elucidate information about people's caring responsibilities, and that was very useful to us. So can we have the next slide, please? I'm just going to give a bit of background on one of the people that we've spoken to, because I think this kind of illustrates the experience of many people. Fatima, it's not a real name, is a refugee from the Middle East. She cares for her husband more than 50 hours a week. When she's not at work, she's caring for her husband who's got a physical disability. When she is at work, her children take over. The family's Muslim, and that prevents a number of issues in terms of accessing support. She gave an example of when she and her sisters cared for the mother before she died. And what she told us was that her sister's husband offered to help to care for her, but he wasn't permitted to because he wasn't a member of the immediate family. And you know, in our culture, she told us, women are not permitted to be alone with a man who's not family, so it wasn't possible to care for him without me or my sister present. Cultural barriers particularly relevant in services where a replacement carer could be provided, and often that's the way the state services work. Said for those from Muslim backgrounds wouldn't like such services because they would be worried about the gender of the carer not matching the gender of the individual being cared for. Fatima told us that she was aware of the Stockton Council Adult Carer Support Service, but said, my husband absolutely would refuse to use the service. When talking about carer respite services, she said, he doesn't want a stranger to come in and care for him instead of me. This is due to the private and sensitive nature of caring duties, for example, using the bathroom. She also indicated that she would have to explain and teach all the cultural and religious practices that must be adhered to. And even if she were to do this, she would find it difficult to trust somebody from outside of the culture to understand and follow those procedures. Much more comfortable having the family providing that kind of support. Also said it would be strange in many cultures in the Middle East to receive support for something that simply one's duty as a family member. There's not a word for carer in Arabic because the word isn't needed. It's an accepted family duty. We then went on to talk to her about what might work, and we talked about information in printed materials, often being translated, not using the word carer, saying that support's available for those who care for somebody when the responsibility becomes overwhelming. So it's about how you present this, how you describe caring, and effectively it's an issue rather than a concept. So if we move to the next slide, please. There was some positive outcomes from this work. I mean, we've interacted with a lot of refugees and asylum seekers in this project and drawn some conclusions from it. The arrival practice is a GP practice in Stockton. It's where many of the refugees and asylum seekers go to register with a GP, and they have put in place a new assessment, or included in their assessment some questions about a person's caring status. And looking to find out more about the background of the individual, and whether they are caring for somebody, even though it's not something which would be described in those terms. Secondly, Stockton Council has a carer support service, and that's introduced a means to work with people speaking other languages. Next slide, please. And ultimately, it's all about trust, and I suppose that applies to anybody. And wherever you're from, whether you're from the UK or somewhere else, you do want to build up trust when you're receiving a caring service. But we're finding that there are extra layers of distrust that needs to be accounted for. And this comment, the service hasn't introduced itself to our communities, is a common one, and maybe that's because it hasn't really found a way of doing that. We think with Mind the Gap, we have been able to make that introduction. I mentioned that there are lots of refugees and asylum seekers who attend drop-in centres, and that's being talked about there. They're having conversations about this project and the services that are available. And we have a refugee and asylum seeker forum that meets every couple of months, and they're talking about it too. Certainly some of the learning points around the distrust and fear of some services. Services lacking diversity, language being a barrier, publicity needing to be culturally informed and understanding cultural expectations and issues, and putting this across in a different way than this is a service for carers, because that's a concept which wasn't understood. So we can go to the next slide, please. We're now looking at ways of building trust, increasing diversity in staff. Certainly our finding, and I think not very surprisingly, that actually staff who were employed in caring services weren't particularly diverse in terms of their backgrounds and their origins. Ensuring staff undergo diversity training. This is something which again was said to us by one of the people we spoke to. At the end of the day, it's too much work for me to explain to the staff of the support service all of the cultural aspects of my family's life and how it affects how I care for my loved one. And even if I do this, how do I trust that they will understand and adhere to those practices? So, it's about introducing the service to the community. I mentioned informational sessions, informal sessions at community centres, going in, having a chat very generally, and then kind of bringing caring into the conversation, using being careful with the language, and the presentation of the information, putting caring into context. So can I take the next slide, please? So in terms of kind of ways forward, I mean, I guess that's the scoping exercise, and there are some useful outcomes from it. In terms of moving to the embedding phase, which is something we'd very much like to do, we do think that there's room for introducing this more informal way of setting up a dialogue with the communities we've been working with into services provided by all sorts of people, and to be honest, not just caring services. This issue about cultural barriers and language applies to other services too. We think that the scope for putting some of this information into the welcome packs that refugees and asylum seekers receive when they come into this country, when they arrive in Stockton, and again being careful about how we put those messages across. So we think there are ways forward to take this forward and embed it. So that's it for me. Thank you for listening.
Thank you, John. That was really, really interesting, and I think trust is just so important for all these groups, and it's very difficult to get and very easily lost as well. So I think it's important that what we promise is actually what we deliver. So is there any questions for John before we move on? We've got about 8 minutes, or is there any questions for any of the speakers from the session 1 within the group? Or any other thoughts? I mean, I think we've looked at different communities, but there are common themes. I think language is a common theme. How do we use, or how do we describe the word carer when it doesn't exist in many languages? That is a challenge, I think, that if anybody has the answer, please share. Neil?
Yeah, thanks. I just wanted to ask a question about potential for digital to help, because we've had a bit of conversation in the chat about that, and my sense has been that there are communities where digital has really helped. So from my experience in Sussex, so carers of people with substance misuse issues have really found that they've been able to attract more people to talk online than they were able to previously trying to work face to face. But equally, we've heard today quite a few communities where digital is a problem. So I'm just wondering if we've got a sense of where digital might help us with some of the inequalities in carer experience, and where I think we're clear about where it doesn't, but are we clear about where it might help?
Anybody? I mean, it's the talks that said that digital wasn't helpful. Tanya?
Yeah, I don't know how relevant this is, but I find as a carer myself, and I work like everybody here, that traditional carers groups in our area face to face are just not available to me because they're during working hours. So one of our local organisations runs online carers support groups after hours. So I find that works for me. So those unsociable hours where other commitments get in with people. I imagine, like with young carers being at school, obviously it's got to fit in with a time that suits them, not so late that they're supposed to be in bed, inverted commas, but allow them time to do homework and have a social life out of school. So I guess timings may be useful when it comes to digital and location. We have a lot of rurality in Somerset. And again, for young carers, the transport is atrocious. So for them who are digitally savvy, as long as their rural locality has a strong enough internet, I'm sure digital, again, would be beneficial in those areas. But there's lots of challenges we have in Somerset regarding digital because of the rurality and as with everyone, financial ability.
I was going to, in my area in Hertfordshire, for instance, the Young Carer organisation is saying that the engagement with the digital online groups is actually dropping off, that young carers have just had enough and they actually want to do some bits face to face. So there's always that both sides. I think the challenge of internet access, who pays for that? You might have a device, but it's not just a device that's required for digital. You do need to have the provider who's going to pay for the provider. So Kerry, I think you had your hand up first.
Hi, yeah, I suppose I just wanted to comment. We have come across a whole new load of carers. I mean, we've been working in Hampshire for over 25 years that have come about because of the digital offer and because of the pandemic. And these are people who, exactly like Tanya was just saying, wouldn't attend face-to-face groups because they didn't want to leave their loved one, because of transport, because of parking. Obviously, Hampshire's quite rural with the New Forest. And we were quite fortunate, you mentioning about the digital and who pays for the broadband and everything. We were quite fortunate that we were successful with a National Lottery grant, and we have tablets and broadband dongles that we loan out to carers around our session times, and we deliver our massive virtual online, and we've tried to see about stopping it, and they don't want it stopped. I mean, we do cooking online, we do art classes, we do Zumba, I mean, it's a huge offer, and they are literally always chock-a-block.
I think that's really important, and it was highlighted in many of the presentations, is that we actually have to adapt for the carers and what the carers want. For everybody, digital is not suitable, but for a really bespoke group, it is. Face to face suits other people. So I think you just have to have the wider offer and allow people to choose what they want. So John.
Yeah, thank you. I mean, yes, it would certainly help, and not just for caring services, but for services more generally. The issue is inevitably financial, and people that we've been working with, the refugees and asylum seekers, but it applies across the community more generally. They haven't got the money to pay for digital devices. We have been able to obtain some through external funding sources, charitable trusts, and so on. Not drop in the ocean, to be honest, but some. But you're still going to pay for your broadband and your subscription fees and all this sort of thing, and there isn't the money to pay for it. So it's a good solution. It will help for some people, but it's being able to afford it.
I know. I think there was a comment about Mobilise, and they find that they've picked up a lot more male carers, and people tend to, from their analytic feedback, is engaged in the evenings or overnight. So I think it gives us a different picture as well, and intelligence that we probably didn't have previously. So I think there's definitely some advantages to it. Now, I'm kind of not quite sure whether to stop if we're going to be naturally transported back to the main room at 12:35. So I think we just continue to talk until we get stopped.
I think we get a 10-second warning, I think, so
Oh,
time to wrap.
So I think what I really like about the Mind the Gap projects is that it's been able to fund projects that, because it is such a small amount of community, mainstream funding wouldn't be able to offer those communities. So I think that's been one of the real advantages of this project. And we've found out information like WhatsApp for the Gypsy, Roma and Traveller community. You know, I think WhatsApp is probably underrated to just what a valuable asset it is for carers and, you know, people in general, but for carers. Has it suited other groups, do you think? Jill?
Yeah, I think it can be used for so many different groups, especially like the voice noting. So if there's any literacy barriers, being able to export text into sort of Google Translate for anybody with language barriers. Yeah, I think there's some real potential to kind of embed that more within some of our communications. And sort of the how easy it is to share information to large groups. You know, if you've got multiple groups that you're engaging with, it's easy to sort of share something or put some information into a group that can then reach lots of people, which I don't think we do the same with like text messaging or emails in the same way.
Do you think we would have exploited the digital options if we didn't have COVID to the extent that we have, or would we have understood the impact that digital has made for carers if we didn't have, you know, 2 years of lockdown and we had to adapt?
Yeah, I think we've definitely learned a lot, haven't we? And yeah, I think it's probably just brought it forward and kind of given it more emphasis. I don't know what anyone else sort of thinks and feels.
Tanya?
Hi, yeah, I just wanted to add, we found, certainly at Health Watch Somerset, at the beginning of the pandemic and reaching out to young people, there was a lot of concerns from organisations and charities regarding the security of WhatsApp, and they tended to tell us not to use it. So we chose not to use it when communicating with our young listeners. I don't know if that's moved on now, but it's just worth a consideration when you've got people like young carers or vulnerable people, that there are concerns about the security aspects, you know, and how they're managed, etc., with WhatsApp. But I think it's a great thing, but I think that there are some legalities, stroke data problems.
Yeah, and I would, that's worth reminding that any group that has young people with an adult, that actually there is, you know, safety concerns and safeguarding issues that surround that as well. And I think everybody needs to be mindful of that. It is always worth reminding, because you sometimes do get complacent on who is in a group. So, but yeah. But I know with the NHS, you know, we tend to move very slowly. COVID did bring us into a more digital footprint, a more established digital footprint than we probably would have. So I think that has definitely been an advantage in the way that we engage. And even to have a meeting like this, could you imagine all of us, you know, trumping up down to London or up north, and that would have been the expectation, and not everybody can do that. So I think it has enabled better platforms. We can record this, so if you don't attend a meeting, you can still get the updates. So it has really 10 seconds done it. So can I do a big thank you to everybody that has presented.
Either we're dead special or they've forgotten about us.
It's weird, isn't it? I'll just let Steve know.